This slide illustrates the concept of multimodal monitoring in critically ill patients, with the goal of identifying what we call hemodynamic incoherence. At the center, we have the patient. Surrounding the patient are multiple layers of assessment, emphasizing a key message. No single parameter is sufficient to understand tissue perfusion. Instead, we need to integrate information from different sources. Starting with clinical symptoms, we look at signs such as fluid balance, elevated intra-abdominal pressure, interstitial or pulmonary edema, and dependence on vasopressors. These findings give us an initial bedside impression, but they are relatively nonspecific and often late indicators. Next, we move to systemic hemodynamics, which include heart rate, arterial blood pressure, central venous pressure, pulmonary artery occlusion pressure, oxygen saturation, and dynamic indices like pulse pressure variation. These are the traditional macro hemodynamic parameters. They help us assess circulation at a global level, but importantly, they do not necessarily reflect what is happening at the microcirculatory level. This is where ultrasonography plays a crucial role. Techniques such as lung ultrasound, VXUS for venous congestion, and cardiac ultrasound for contractility allow us to better understand cardiac function and fluid status. Ultrasound bridges the gap between static numbers and real-time physiology. Moving further, we assess the sublingual microcirculation, which is essential in this concept. Parameters like microvascular flow index, total and perfused vessel density, red blood cell velocity, and the perfused boundary region give us direct insight into tissue-level perfusion. This is where we often detect abnormalities even when systemic parameters appear normal. We also incorporate advanced hemodynamic monitoring, such as thermodilution techniques. These provide quantitative measurements like cardiac output, stroke volume variation, systemic vascular resistance index, extravascular lung water, and global end-diastolic volume. These help refine our understanding of preload, afterload, and fluid responsiveness. Finally, laboratory tests complete the picture. Hemoglobin, central or mixed venous oxygen saturation, the venous to arterial CO2 gap, lactate levels, inflammatory markers, coagulation parameters, and indicators of endothelial injury all reflect the consequences of impaired tissue perfusion. When we integrate all these modalities, we can identify different clinical phenotypes of hemodynamic incoherence. In other words, patients may have similar blood pressure or cardiac output, but very different microcirculatory and metabolic states. The key takeaway from this slide is that normalizing blood pressure does not guarantee adequate tissue perfusion. Therefore, effective resuscitation requires a comprehensive, multimodal approach to truly optimize oxygen delivery at the tissue level. This slide explains the concept of hemodynamic incoherence by comparing two key components of circulation, macrocirculation and microcirculation, and how imbalance between them affects patient outcomes. At the center, the balance symbol represents the idea that adequate tissue perfusion requires harmony between these two systems. When they are aligned, oxygen delivery meets tissue demand. When they are not, hemodynamic incoherence occurs. Let's start with the macrocirculation, shown on the left side. This includes the parameters we routinely monitor in clinical practice. First, oxygen delivery, which depends on hemoglobin and arterial oxygen tension. Second, arterial blood pressure, which ensures sufficient perfusion pressure. Third, cardiac function, including cardiac output and stroke volume, reflecting the heart's pumping ability. Fourth, fluid responsiveness, assessed by dynamic indices such as stroke volume variation, passive leg raising, or pulse pressure variation, helping us decide whether fluids will be beneficial. And finally, global tissue perfusion markers, such as lactate, venous oxygen saturation, and the veno-arterial CO2 gap. In many cases, we optimize all these parameters. However, the key question is tissue perfusion truly restored? If the answer is yes, the patient progresses to shock remission. But if the answer is no, despite apparently normal macrocirculatory values, the patient remains in unrelieved shock. This situation defines hemodynamic incoherence. At this point, we must shift our focus to the microcirculation, shown on the right side. Using a multimodal evaluation, we assess tissue-level perfusion and identify specific pathophysiological phenotypes. These include stasis, where blood flow is sluggish or stagnant. In this case, treatment may involve reducing fluid overload, optimizing PEEP, and lowering intra-abdominal pressure. Leakage, characterized by capillary permeability and fluid extravasation. Management focuses on restricting fluids and using therapies such as albumin or anti-inflammatory strategies. Occlusion, due to vasoconstriction or microthrombosis. Treatment may include adjusting vasopressors and, in selected cases, vasodilators. Obstruction, often related to coagulation disorders and endothelial dysfunction. This may require blood purification techniques or modulation of the coagulation pathway. And paralysis, where vascular tone is severely impaired. Here, vasopressors or agents like methylene blue may be considered. Finally, if the condition still does not improve, we must consider a deeper level problem. Disorders of oxygen utilization at the cellular or mitochondrial level, where oxygen delivery is adequate but cannot be effectively used. The key message of this slide is that normalizing macrocirculatory variables alone is not enough. Effective resuscitation requires identifying the underlying microcirculatory phenotype and applying personalized, targeted therapy. In short, restoring blood pressure does not necessarily mean restoring tissue perfusion. This slide presents a practical bedside algorithm to interpret elevated lactate by integrating three key parameters: lactate, central venous oxygen saturation, ScvO₂, and the veno-arterial CO2 difference, or PvaCO₂. The goal is to answer a very important clinical question. Is lactate elevated because of true tissue hypoxia or due to other mechanisms such as microcirculatory dysfunction or impaired oxygen utilization? Let's go step by step. We begin with lactate. When lactate is elevated, typically above 2 mol per liter, it signals that something is wrong at the tissue level. However, lactate alone does not tell us the exact cause. It can increase not only in hypoxia, but also in sepsis, inflammation, or catecholamine stimulation. So, we need additional information. The next parameter is ScvO₂, which reflects the balance between oxygen delivery and oxygen consumption. If ScvO₂ is low, below 70%, it means that tissues are extracting more oxygen than usual. This usually suggests inadequate oxygen delivery. If ScvO₂ is normal or high, 70% or above, oxygen delivery appears sufficient, or the tissues are unable to utilize oxygen effectively. However, ScvO₂ alone is still not enough. This is where PvaCO₂ becomes essential. PvaCO₂ is the difference between venous and arterial CO2. It reflects how effectively blood flow removes CO2 produced by tissues. In simple terms, it is a marker of circulatory flow or cardiac output. If PvaCO₂ is greater than 6 millimeters of mercury, it suggests low blood flow, meaning CO2 is not being cleared properly. If it is 6 or less, blood flow is generally adequate. Now, by combining ScvO₂ and PvaCO₂, we can identify 4 main clinical patterns. First, when ScvO₂ is low and PvaCO₂ is high, this indicates both insufficient oxygen delivery and low flow. This is typical of low cardiac output shock, where tissues are truly hypoxic. Second, when ScvO₂ is low but PvaCO₂ is normal, blood flow is adequate, but oxygen delivery is still insufficient. This often points to reduced oxygen carrying capacity, such as anemia or hypoxemia. Third, when ScvO₂ is high but PvaCO₂ is elevated, oxygen appears available, but blood flow at the microcirculatory level is impaired. This pattern suggests microcirculatory dysfunction or hemodynamic incoherence, commonly seen in sepsis or excessive vasoconstriction. Finally, when both ScvO₂ and PvaCO₂ are normal, yet lactate remains elevated, this raises suspicion for mitochondrial dysfunction, where oxygen is delivered but cannot be effectively utilized by the cells. The key message of this slide is that elevated lactate is not a diagnosis, but a signal. To understand its cause, we must evaluate both oxygen delivery and blood flow, and sometimes even cellular metabolism. In summary, ScvO₂ tells us about oxygen, PvaCO₂ tells us about flow, and lactate reflects the consequence at the tissue level. This integrated approach allows us to move from a generic resuscitation strategy to a more targeted and physiologically guided treatment.